everyone to our annual Global Cardiovascular Health Visiting Professor Series for 2021. My name is Jerry Bloomfield. I'm an Associate Professor of Medicine in the Division of Cardiology here at Duke and Associate Research Professor in the Duke Global Health Institute. I am joined by my esteemed colleague and co-moderator, Dr. Neha Pagadipati, Assistant Professor of Medicine and leader in the Duke Cardiometabolic Disease Program. We'd like to welcome all of you joining from all around the world and wish everyone safety and health during this worldwide pandemic. This past year has taught the global health community many important lessons, and perhaps the greatest among them is the truth that we can accomplish great things when we come together with a unified purpose and resolve. Partnerships that bring together different disciplines, methodologies, and experts from around the world are the hallmarks of our success in global health. Even as we reel from ongoing infectious disease pandemics, the insidious devastation from non-communicable diseases and their effects on households, communities, and economies, and society at large remains largely unchecked, and we are in dire need of leaders to help chart the way forward. Well, we are fortunate today to have one such leader as our Global Cardiovascular Health visiting, or I should say Zooming, professor this year in Dr. Zainab Samad. Dr. Samad is Professor of Medicine and Chairwoman of the Department of Medicine at the Aga Khan University in Karachi. She's a board-certified cardiologist, having trained in internal medicine and cardiovascular medicine right here at Duke. After serving on the Duke faculty for 9 years, Dr. Samad returned to her home country and her home institution to become the first woman to chair the Aga Khan University Department of Medicine. Dr. Samad serves in a number of professional venues and has consistently received numerous awards for her teaching and her scholarship. Moreover, she's an accomplished researcher with over 100 publications and external funding for her active research in cardiovascular disease from industry and public sources. During her tenure as chairwoman, and maybe she'll talk some about this today, Dr. Samad spearheaded the first national NCD think tank with representatives from multiple sectors across Pakistan to address cardiovascular disease and non-communicable diseases in general, really setting an example for the country and the region. Dr. Samad is a dear, longtime friend. She's a wonderful collaborator and is the ideal person to speak to us on partnerships to improve cardiovascular health and research capacity, lessons learned from the Aga Khan University experience. Welcome, Zainab.
Jerry, thank you very much for that very, very kind introduction. I'm going to share my screen here to get the slides up. So I think you guys can hear me, right? So it's a real pleasure to be able to address many folks from around the world, but more importantly, one of my dear, dear alma mater and dear friends at Duke University. And this topic is actually close to my heart because it addresses partnerships. It brings institutions together to address big problems like cardiovascular disease. And I want to be able to touch on the Akhan University experience. The outline of my talk is going to hit upon a brief introduction that I know Jerry was very kind to give, then an introduction to Akhan University, what the cardiovascular health landscape looks like in Pakistan, and how our different partnerships have helped us understand disease better and even intervene in this space. I will briefly touch upon the Duke and AKU collaboration that's ongoing and some final thoughts. So my journey, and Jerry touched upon this a little bit, I want to show you the globe here. So here is Pakistan right next to India and Iran and Afghanistan. I was born in Karachi, which is a southern city, similar to North Carolina, and similar to Durham, very southern, in Pakistan, and went to medical school at St. Joseph's Convent and then medical school at Aga Khan University. I graduated in 2000 and then was very fortunate to land a residency spot in internal medicine at Duke University Medical Center, which I started in 2002. I started my cardiology fellowship and completed that from 2005 to 2009. During the same time, I also did a master's in clinical research from the Duke CRTP program that I know others have done as fellows at Duke. Stayed on faculty for several years, made lots of friends and relationships, and learned so much during that time. And in 2018, was very fortunate to be recruited back to my alma mater as the chairwoman of the Department of Medicine. So that's my journey. And I think I'll tell you a little bit about one of the two very dear institutions. And one of them is the Aga Khan University that I currently serve. So who we are is, I believe that we're leaders that raise standards and break ground in the countries that we serve in. We partner and build collaborations locally and internationally with both government and private institutions on the basis of shared values. The principles being impact, quality, relevance, and access, and that's an acronym for ICRA, which in Arabic means to read. I think we are problem solvers where our research focuses on the challenges facing the majority of our populations. We educate leaders, preparing young people to lead change at home and succeed in the global knowledge economy. And we have a healthcare system that meets international standards and serves the disadvantaged. We are not for profit where people come first. Our philosophy is best described here through a quote from His Highness the Aga Khan, who's also the Chancellor of the Aga Khan University. What is required today is an educational approach that is the polar opposite of indoctrination, one that nurtures the spirit of anticipation and agility and adaptability and adventure. We work in several different countries. I'm located in Pakistan at the flagship site that started back in 1983. We have sites in Uganda, Tanzania, and Kenya, which have been operational since 2000. The United Kingdom, which has the Institute for Study of Muslim Civilizations since 2002, and Afghanistan, where we have the FMIC since 2006. There are over 2,000 students served by AKU and studying at AKU. Majority of these are in Pakistan and many in East Africa, the UK, and Afghanistan. Over 16,000 alumni have left the walls of AKU. AKU has 18 degrees and diplomas, and across its various campuses, there are 65 residencies and fellowships. Some important things to note about AKU is that 75% of the students receive financial aid from AKU or receive free tuition in exchange for working at AKU post-graduation. And an important thing to note is that 2 out of 3 students are women, and 1 in 2 faculty are women. We have the medical colleges in Pakistan and East Africa, a school of nursing and midwifery, both in East Africa and Pakistan, and an Institute for Educational Development, both in Pakistan and East Africa. There's a graduate school of media and communications in East Africa, and then the ISMC that I mentioned earlier in the UK. We have an examination board that has really raised the standard for examinations, and this is in Pakistan. There are several centers and institutes that are dedicated to studying big challenges. These include maternal and child health, human development, and so on. I wanted to share some pictures of the place that I work at, an AKU in Karachi. This is the entrance to the medical college. It is supposed to signify a ray of light. And I really believe, and I hope I can convince you, that through partnership and working both locally and internationally, we're able to build capacity in several different spaces, including cardiovascular diseases in Pakistan. Here's the School of Nursing, and this is the back of the hospital. This is the university center that is going up right across from the hospital in Nairobi, hospitals in Tanzania, Uganda, and this is the ISMC, Institute for Study of Muslim Civilizations. The health system is one of the big, health and education is what AKU primarily works in. And the health system encompasses 7 hospitals, 5 of which are in Pakistan, 1 in Kenya, and 1 in Afghanistan. We have a very large network of outreach medical and laboratory centers spread across Pakistan as well as in East Africa. And across our multiple campuses and this entire health system, we see about 2.2 million patients per year. In Pakistan alone, we see about 1.4 million patients. And these patients come from a very large socioeconomic strata. AKU provides subsidized healthcare annually through its patient welfare program for 700,000 patients, and this is on an annual basis. And 1 in 10 inpatients at the Aga Khan University Hospital earns less than $2 a day. This is an aerial view of our campus in Karachi, Stadium Road. These are secondary hospitals in Pakistan, which are dedicated primarily to maternal and child care. And this is a screenshot of the hospital in Nairobi that I know Jerry has visited at least once. And here is the French Medical Institute for Mothers and Children in Kabul. There's several fellowship programs. In fact, they have a cardiology fellowship program, and several of their cardiology fellows have visited us in Pakistan here as well. This is a pictorial view of how the health centers, the research centers are spread across Pakistan. So pretty wide area is covered through our health system. A little bit about alumni. We have several alumni who've gone on actually to train at Duke and do big things. One of them is the president of the Gender Equality Division of the Gates Foundation. Her name is Anita Zaidi. She actually did her pediatrics residency at Duke after graduating from AKU. The director of the Yale Institute for Global Health is also an AKU alumnus. This guy pictured right here amongst students is our dean and also an AKU alumnus. And we recruited him from the Brigham and Women Hospital, where he was directing the Kessler Center. Nursing profession has really been raised by AKU in Pakistan. And I'm proud to share with you that 8 out of the 100 global top nurses and midwives list, 8 of them were AKU alumni. I also want to share with you that, the university was built to serve the communities that it resides in. And a lot of our graduates actually stay in those communities and serve them. The economic impact of AKU has been measured, and it's about $1 billion in Pakistan alone. And this is through alumni operations and hospital care. And since we're talking about cardiology and the cardiovascular health space, there are several firsts in cardiology that are contributed to by AKU. These include a structured residency program, several fellowships, a cardiac MRI service, and the fact that I want to be able to tell you and share with you that 55% of our cardiology fellows are women, and this is something that we've changed over the last 3 years. So given that background and that introduction to AKU, I'd like to be able to share with you a few things about cardiovascular health in Pakistan, what the landscape looked like, and what the different partnerships we've leveraged to not only understand disease, but also to improve CV health. But before I delve into that, I want to just give you a few indicators on the background against which we look at cardiovascular disease in our country. And here you can see, this is population estimates provided by the GBD, IHME, that Pakistan is a fairly populous country. We are 5th most populous country in the world, and our population sits at about 220 million now, and is expected to go up. Most of these are young individuals. Most of our population sits under the age of 50. The average age is something like 19 years. And so what is the health system and the resources that serve this population? It's not a lot. As you can see, these are statistics that I have accessed from the Pakistan Bureau of Statistics. And we have 14,000 institutions serving this size of a country, around 200,000 doctors and less than 150,000 nurses serving Pakistan. So summary, fifth most populous country, young population, the average life expectancy is 62 years and happens to be actually the lowest amongst the South Asian nations. We have a 59% literacy rate, and this is lower for women compared with men, and the average income is $422. So what do we do in a country that spends less than 1% of its GDP on health? We expect that the health systems aren't geared to understand or to are equipped to deal with cardiovascular diseases, other NCDs. And then probably the surveillance, and we know for a fact that the surveillance, although surveys are done, they're done with large time periods in between them. So where are the partnerships that we can be leveraged to understand disease better from Pakistan? And I can say that our cardiology section in the Department of Medicine has been very active in contributing data to several international efforts. And these includes InterHeart, InterStroke, and Pure, led by Salim Youssef at McMaster's. And these contributions have helped understand disease better from Pakistan. We are also very proud collaborators for the Global Burden of Disease Study, which models and provides estimates of disease, which I will share with you in just a little bit. This is a visualization, a very nice from the GBD visualization tool. As you can see, this represents causes of death for 2019. And you can see that non-communicable disease and injuries occupy a large proportion of deaths in Pakistan. And obviously cardiovascular disease is a big contributor. Here are rankings, and this shows you how that ranking for causes of death, the top 10 causes of death, has changed between 1990 and 2019. The big points to note are the fact that cardiovascular diseases have now become the #1 cause of death. Diabetes has gone up, cancers have gone up in ranking. But also note that at the same time, while we're struggling with these NCDs, maternal and neonatal diseases are still around. Respiratory infections, enteric infections, TB are still around and are still contributing to top 10 causes of death in our country. Here's an NCD risk factor survey, the earliest one, the latest one that I could find back from 2014. And this shows you that and this was actually supposed to be done across all provinces in Pakistan, but then ended up being in the 2 most populous provinces, which is Punjab and Sindh. And what you can see here is that 40% of the population has 3 or more risk factors for cardiovascular disease, a fairly high risk factor burden. And you should keep this information against the context that our population is still very young. We haven't quite entered the time period where, or the ages where CVD becomes a problem. Also note huge lifestyle issues over here. So nobody eats fruits and vegetables, it looks like, from this survey. And the percentage of people who are not meeting WHO recommendations for physical activities is fairly high, and much higher among women than men. And I believe this has to do with structural issues and cultural issues in Pakistan. This is data from the WHO and the country profiles. It's available on their website. And you can see that tobacco smoking is big, more in men compared with women. Obesity is rising, more in women compared with men. And raised blood pressure is again rising. So we kind of not heading towards meeting our goals to reduce these. This is data from 2014 from the Pure study, was published in the New England Journal of Medicine. So Pakistan kind of lands in the middle income group of countries, at the lower middle income group of countries. And you can see here that the ages, young individuals, high rates of smoking, high rates of an unhealthy diet, low physical activity, hypertension is very prevalent, obesity is going up. But if you look at the InterHeart risk score that includes a lot of these risk factors, the InterHeart risk scores actually lower in middle and low income countries compared to high income countries. But this paper actually looked at a few other things, and they looked at event rates and they looked at case fatality rates. They found that while the inter-heart risk score was actually lower in middle and low income countries, which Pakistan is one, the event rates were higher compared to high income countries. And there was a clear urban-rural disparity. The case fatality rates were also higher in middle and low income countries compared to high income countries. And again, there was this urban-rural disparity, and clearly it reflects on the access to healthcare, both preventive and management for cardiovascular disease. Incidence of disease was also higher in middle and low income countries. So in this area of what I call a data vacuum, if you look up data from low middle income countries, it's very scarce for cardiovascular disease. A lot of the estimates are generated through modeling efforts from similar populations, from neighboring countries, from surveys that perhaps are outdated. So when I came back as chair, and the work that I'd previously done at Duke in terms of looking at our data, I said, what are the data sources that we can use within AKU to understand and contribute to our understanding of cardiovascular disease in Pakistan? And what we found was actually a treasure trove of data. There is data sitting in our coffers since 1988. Since the hospital opened up, there's claims billing data, there's administrative data, pharmacy, imaging, lab, inpatient emergency systems. And so we created a demonstration project looking at specifically acute myocardial infarctions. I wanted to see what the patterns look like, how have they changed over the last 30 years. And so we pulled out acute MIs based on IC9 diagnosis codes. We removed repeat visits, so only index visits were counted. And we ended up with a data set of over 14,000 patients, unique patients with acute MI. And I just want to share a few insights. So given similar to what we've seen, and this is really triangulation of data and information, that CVD is going up. You can see that the admission numbers have gone up across that 3-decade time period at AKUH. At the same time, the age at presentation for MIs. Now in this graph, we have combined both non-STEMIs and STEMIs. You can see that the age at presentation has gone up, but you also notice, this is mean age at presentation. Also notice that these people are much younger than Western counterparts. I mean, MIs present in 70s now in the US and UK, and these guys are much younger. And if I drilled it down to just ST elevation MIs, where, clearly high mortality, those folks haven't come out of the 50s. They are still in their 50s over 3 decades. This graph shows you two things. One, the absolute numbers coming in with an MI. The blue lines represent men and the pink women. And you can see, and actually the colors represent the age gradient, that men are generally younger than women when they come in with the MI. There are fewer women with MIs than men. So actually the proportion of MIs that presented in a particular year, about 30% are women, 70% are men, and it's similar to other statistics across the world. Notice that the age has gone up across the decades for both men and women. But also notice that the difference between men and women is not that much. Although women are older, we see a much bigger age difference in Western literature and Western counterparts compared to what we're seeing here in Pakistan. But despite that, be it having older individuals coming in, the admissions have gone up, the mortality has actually come down. This is in-hospital mortality over the last 3 decades. And I'd say that there are 2 contributors. One is the fact that there's probably use of guideline-directed medical therapy, and the fact that we launched a primary PCI program, the first in the country in this time period here. So these are insights, and there's a lot more that we were able to glean, and this is work that Jerry has contributed to. So we glean a lot of insights just from our data, and the data set is large. I at least haven't heard of a similar exercise or use of such data from a low middle income country. But I want to just switch gears and point out to you this very interesting graph that was published recently in the Lancet in a paper called The 5 Insights from the GBD. And what they're showing here is the health coverage, UHC, across social demographic index quintiles. Now, what they're showing is that CMNN diseases, this has a linear relationship. So as DI goes up, CMNN diseases coverage is very nice, tightly linked. But when it comes down to the middle and lower quintile nations, and Pakistan sits right there, there's a clear gap. And these are the nations that actually have suffered the most rapid transition in DALYs and death attributed to cardiovascular disease and other NCDs. There is a clear gap in health coverage interventions for NCDs and CMNN diseases. So, and this is something that I hope that that's been demonstrated in the previous work that I just shared with you. Oops. So summary, the last few slides, that the last 3 decades have seen a rise in NCDs. CVD now is the #1 cause of death. We clearly are dealing with a double burden where while we're struggling with infections and maternal neonatal diseases, we now have on our hands diabetes, cardiovascular disease, and neoplasms and other NCDs going up. The risk factor prevalence is rising, and our health systems are clearly not set up or equipped for this NCD challenge. And I really believe that that pyramid that I showed you of the ages and how most of our population is young, that I think's got it's a double-edged sword, right? On one hand, it really represents a window of opportunity for us in that those young folks haven't entered the period where they are clearly vulnerable, they're clearly could get hit with CVD. So it represents a window of opportunity for prevention, preventive efforts for us. But on the other hand, if those people move into the vulnerable age groups where CVD is highly prevalent, I don't think that we have the health systems ready or equipped to deal with that challenge. It's too costly. It's too costly. So what are people and what are rock stars doing to actually address some of these challenges and do it in a way which is low cost, which is acceptable to the communities in Pakistan? And I want to point out the work of one of my favorite people, Dr. Kazeen Jaffer, who is a member of the Duke Global Health Institute. She is actually an alumnus of AKU. Who trained in the US, came back and set up a really fantastic research program across Pakistan and several other countries actually around hypertension. And one of the works that was recently highlighted was actually around the use of multi-component interventions to reduce high blood pressure. And then she does randomized cluster trials in rural Pakistan. Her most recent paper that came out was the COBRA BPS study, which was a collaboration between AKU, Duke NUS School, and sites in Bangladesh and Sri Lanka. And what it showed was that a multi-component intervention in the rural setting actually really improved blood pressure control and was feasible in all these countries. So these are the kinds of interventions that need to be tested. And obviously this work doesn't come out alone. It has to be done in partnership and collaboration. This is the work of one of actually the students of Dr. Tazeen Jaffer. I think Aisha Almas, one of our collaborators and one of my faculty in the Department of Medicine, she did this work on a school health education program to see whether that would be efficacious in terms of improving physical activity and other cardiometabolic risk factors. And the study actually demonstrated, this is the methods paper, but essentially looking at feasibility as well as efficacy of a threefold intervention. And I think that study really is targeting that young population that's about to enter the vulnerable period. A shout out to one of our local cardiac institutes that's very famous in cardiovascular disease healthcare delivery. It's the Taba Heart Institute. It's actually led by one of our own alumni, Dr. Bashir Hanif, who also directs the Cardiac Registry of Pakistan. This is a nationwide registry, recently started in, I believe, 2016. And it is documenting all percutaneous interventions conducted and their outcomes in Pakistan. So this is the kind of work that's been done. A lot of it has been done by AKU alumni, AKU collaborators, and really everybody's trying hard to not only understand the disease, monitor the disease, but to come up with interventions that are feasible. And now I want to just switch gears and talk a little bit about the AKU and Duke collaboration. This has been ongoing for several years. In the fact that several of our medical school graduates have come and trained at Duke. Some of them have left, others have come back to AKU to serve. And when I was coming back in 2018, Jerry and I sat together and were brainstorming areas that really would be able to produce impact in this space. And we were very fortunate to actually be awarded a planning grant for the development of a research program at AKU. Here is the conceptual framework for why that would be necessary. I've shared with you that there is scarce data that the health expenditure is low, so research expenditure is even lower. And we really need to come up with ways to bring together a cohort of individuals who will not only work in the NCD space, but be particularly equipped through research tools to make a difference. And this is important. This is one, this actually effort would address the global action plan objectives delineated by the WHO. And I believe that this would contribute to breaking the vicious cycle that is happening in LMICs, where NCDs are rising. They will contribute to increased premature death, loss of productivity, stunted economic growth, and then that then contributes again into a rise of NCDs further and shared risk factors. And obviously has effects down on the ability of low-middle income countries like Pakistan to meet their sustainable development goals. So our planning grant had to do with understanding the need for a training program, what would potential barriers look like, and what kind of a program would be responsive to that. And so this paper has actually just been submitted to one of the BMJ journals. I think we got some good reviews, Jerry. But it addresses a qualitative study that we did, it involved interviewing a variety of different stakeholders to look at what would be the priority. And clearly cardiovascular disease came out as a big priority. In terms of methodologies, people are interested in the latest technologies, or the technologies that you utilize non-traditional methods, that are going to be less expensive. So leveraging mHealth, data that's acquired as a byproduct of clinical care or other means. And how can we integrate understanding these research methodology trainings into what's already being delivered as curricula for health professionals during the lifespan of training. Barriers identified include the fact that we don't have very flexible training programs. There's high costs associated with it, and there's ambiguous research career paths, and mentorship is an issue. And you know, the interview, the people who were interviewed identified several avenues that could be looked at in terms of addressing some of these barriers. One of the things that came out was also national bodies focusing on NCDs. We found that to be a vacuum. And so we went ahead and tried to address, besides developing a proposal for a research training program that was very needs responsive, we went ahead and said, okay, what are the things that we can immediately get started on that we don't need to sit around and wait for funding? One of the spaces, again, highlighted from some of the work that was funded by this grant is we looked at research output as a cardiovascular publications as a surrogate for research output. And what's shown in this figure is that while a lot of the population of the world sits in low and middle income countries, and they burden a significant portion of DALYs and deaths attributable to cardiovascular disease, that their contribution to that global cardiovascular research output, a publication output, is actually very, very low. So this is what we would want to be addressing. One of the things that we said we'll go ahead and immediately do work on is we launched a think tank that's national. It's truly multi-sectoral because we feel like this is not something that can be just handled by researchers and healthcare professionals. It's got individuals from media, from the finance, from insurance companies, from marketing agencies, the food industry, and obviously health professionals and researchers. And Dr. Jerry Bloomfield and Tazeen Jaffer actually serve as advisors to this think tank. This was launched back in 2018, and we've had our first meeting back then. Additional things that we have collaborated on since I came back is the Pulse Conference. This was initiated. Obviously, we're looking at a vacuum. We're looking at, besides the Pakistan Cardiac Society, which is kind of takes leadership role in developing and disseminating information around cardiovascular diseases, we felt like this is something that we could offer high quality teaching material, high quality dissemination of knowledge. And you can see here some familiar faces. That's Joe Kislow, cathing a mannequin, and also doing an echo on a mannequin. I think you guys should save these pictures. And then we have Eric Velasquez, who was associated with the DGHI and now is the division chief of cardiology at Yale. We've got Dr. Fayez Zanat, who is a famous cardiovascular clinical trialist. And these are some of the leaders in the cardiology space in Pakistan. This was a very prominent, very well-received conference, and very proud that several Duke speakers were featured in it. That was 2020. Also, in 2019, we were able to send one of our star cardiology faculty, who's now the interim section head for cardiology, to train at Duke in DCMRC. Her name is Dr. Saira Buhari. She is now one of the 2 trained cardiovascular MRI faculty in Pakistan, actually. So this is big. And also one of the things that was highlighted was mentorship and how do you build research programs. So we got a bunch of super stellar faculty from both Duke and AKU to come together and deliver a series of lectures in a webinar series that Dr. Jerry Bloomfield and I co-directed. And you know, this is very well received. People from all over the world logged on and listened to them. We got great feedback. And I think a lot of learnings were transferred. A lot of learning happened in this. This year, because of COVID, and which is also making it possible that we interact more frequently, but on video, we had the 2021 Pulse. It was focused on gender. Again, a topic very close to my heart and important. And we were able to have several Duke faculty featured on this conference. It got a lot of press. So again, these are just examples of our collaboration that is building capacity in this area in Pakistan. But not only Pakistan, because the footprint of AKU is really truly global and covers several low-income countries. That learning is transferred in those places as well. So to summarize, we've had several partnerships, especially with Duke and ongoing, that are addressing capacity, knowledge transfer, surveillance, monitoring, evaluation of cardiovascular disease. Some of these are addressing community level and health system level interventions, and they need to be ongoing. This is a big challenge. It can't be done alone. I think, final thoughts here. I feel like as mankind, I think we are, these are our big challenges. This is my top 4 list. It's conflicts, it's disease, it's poverty, it's planetary degradation. And I think inequity is a driver, a major driver, and a cross-cutting theme across all of them. And these are things that can't be addressed with us, each of us sitting in a room and looking at the wall. They have to be addressed facing each other and working across boundaries, artificial, real, or imagined. I want to end with this quote from His Highness the Aga Khan, our Chancellor, which he has shared through a lecture in 2010. And it says that almost everything now seems to flow globally: people and images, money and credit, goods and services, microbes and viruses, pollution and armaments, crime and terror. But let us remember too that constructive impulses can also flow more readily, as they do when international organizations join hands across dividing lines. So this is my final thought. And thank you very much for listening, and happy to take questions.
Zainab, thank you so much. I think, just watching this, and this doesn't even encompass your entire body of work. It is, I'm so impressed, but also I'm just so proud of you. You've done so much amazing work and continue to do so much. And you are like literally doing what all of us want to be doing, because you're actually changing the world. So I think we're so incredibly proud of you, and thank you for sharing, these insights with us. I just want to let all of the participants know that the Q&A is open, and so please type in your questions into the Q&A, and Jerry and I would be happy to kind of bring up your questions for Zainab to respond to. But I'd like to start with one, if that's okay. So one thing I would love to know, you've obviously gone back and you've done so many amazing things. What was it like for you? Like you've been in the US, you've been at Duke for a very long time, and then you move back and you take a really high leadership position. You've been gone for a long time. What were some of the challenges that you faced as somebody who was coming back to the US, as a woman, as a cardiologist? What were some of the challenges that you faced? And then what were some of the things that surprised you or that went surprisingly well?
So, Neha, it's that's a very good question. See, when you move from a high-income country to Pakistan, you're kind of used to a certain. So I'd say the challenges really came from the lifestyle things that one gets used to, and the ease of things that one gets used to. I'm being very candid over here, okay? One gets used to in the US, like your water's not going to run out in the middle of the shower, the electricity isn't going to be gone for several hours a day. Those kinds of things were the challenges. But with every, I feel like in life, as they say, that there is nothing there's trade-offs for everything, right? This was a great opportunity to give back. When I was interviewing as a medical student, I remember telling the interviewers here, not as a medical student, as somebody trying to get into AKU, that I wanted to give back. This is something that they look for in the med students. They ask, what is your idea of social responsibility? And I remember sort of really going very passionately on this topic with the interview. And that always kind of stuck with me. And so this was, you don't know how long you have to live, right? You don't know. And so this was important for me. And those other things, those appear minor in the face of being able to deliver on some of those promises. And it was really awesome to be close to home, close to my parents. And really AKU has the national and international standing, allows you to make big changes. Just an example, when this pandemic hit us, we were the first hospitals to have a COVID-19 patients when people are scrambling and saying that, maybe we don't want COVID-19 patients admitted in hospitals. And because, that's the kind of thing that happens in this panic confusion. Our faculty have consistently provided advice at the highest level to the government. We developed a COVID tele-ICU project. The PI is one of my good friends and the chair of anesthesia. So anesthesia and Department of Medicine collaborated on this project where we've delivered over 1,000 tele consultations peer-to-peer to individuals who are taking care of COVID patients in ICUs across the country. And so this, I was just thinking, what other institution would allow me, what other place would allow me to make that kind of impact, to work with some of the brightest minds in Pakistan to make that kind of impact. So yeah, it's been great. There are challenges, but it's been great.
Well, I was just going to say, to your point, I think throughout your talk, you mentioned kind of service and doing things in service of others. And I think that was very prominent in your talk, and is obviously something that is kind of part of the ethos of Aga Khan University, and is clearly coming out. I do have a comment and a question from the amazing Dr. Swati Shah. So she says, Professor Samad, you are an incredible advocate for non-communicable diseases and have made such a huge impact in such a short amount of time. Very true. What are your thoughts on how South Asian countries can work together to understand unique risk factors and cultural factors in risk of heart disease? And by the way, we miss you so much.
I miss you so much too. So a great question, Swati. I think, honestly, if you look at some of the data that I presented, you see the inner heart risk score is lower compared to high-income countries, yet our incidence is higher, yet our event rates are higher, our case fatality rates are higher. I think there's a lot of opportunity for us as a group of countries. I think there's shared genetics, there is shared cultural, social factors. And I'll plug in a word for women. There is so much structural barriers to women accessing care for cardiovascular disease, their understanding of cardiovascular diseases, the way how genetics may contribute to disease, how inflammation can contribute to disease, and we still have diarrhea sticking around, right? So first several years of our life is diarrhea, and then suddenly you hit 15 and 16, and then you start getting obese and develop early CAD. Is it inflammation? Is that early inflammation that's causing CAD? So I think there's lots of theories that can be tested, and I think it's a great opportunity for like Swati, yourself, Neha, Jerry, and us to kind of pool resources, pool our collaborators, and work across. The Zine has done it. We can, we can form similar consortia.
Great, and I know that Jerry has a question. Jerry, go ahead.
Yeah, I was as we're getting more questions here from the panel. I won't. I mean, that's such an amazing talk. I'll try not to get flabbergasted in response to it. But there's this one thing that you mentioned is, you outlined very well the barriers, the challenges, and you also highlighted Tazeen Jafar's COBRA BPS approach, which really, attacked this problem of CVD at the community level. And I wonder if you could talk about, what are your thoughts on how scalable that is, you know, in the area that you work in, this idea of things that I think we all, you know, laud to be important, you know, interacting with the community to really mitigate some of these risk factors. How scalable is that in Karachi or Pakistan, for example?
I think, Jerry, that is very scalable. Okay. One of the reasons why I think that's the case is that kind of COVID-19 has shown us how care is provided in Pakistan, how our families and how our people want to be cared for. And the care sits in the community. They would want to have it reside at home, right? We didn't have a lot of people coming to the hospital. There's people sitting with oxygen tanks and steroids and whatnot at home, okay? And so it means that a lot of work can be done in the community using what we have in terms of trained personnel. We have a very large government community health worker program that's been leveraged for maternal child programs. We and this is what Tazeen's work has done, you know, adding blood pressure screening, monitoring, etc., and health education around hypertension to that portfolio. How can we outsource from the main tertiary centers and hospitals the work to the communities itself? It's very scalable. I think COVID-19 has shown us that there is great appetite for it, and not just something that sits in a trial in a control setting. It can be achieved. But it really requires a lot of people working together, the government, developing policies, training a workforce. And I think here I'll put in again a plug for gender and a plug for women. Even though our literacy rate is not very high, there is this entire workforce that's untapped at this point. You know, one of the things that can be done is really developing a workforce primarily contributed to by women that can do community engagement and community education around these NCDs and lifestyle risk factor modification. And I think that's something that that represents an opportunity for us, and I think can be scalable. Two birds with one stone.
I just wanted to say Maria Raposa didn't have a question, but she said that you gave a wonderful presentation. It was extremely impressive, which I think we can all agree. I have another question, if that's okay. Several times you've mentioned, you know, it's all about partnerships, right? And partnerships with different organizations, different academic organizations, international organizations. But I'd love to hear more about your experience with the partnership with the government, both the local and the national government. I think that's something that, you know, is a little bit different from the US context. And I'd love to understand, you know, what has that been like for you? What has your experience been? Yeah, how's that worked so far?
So, you know, here is the thing. Our partnership with the government has been, we reached out to them around NCDs. We have representatives from the government, the finance ministry and the National Institute of Health of Pakistan on our think tank. That's governmental involvement, but we really, truly partnered with the government when COVID hit, right? So I recognize that when there's a need and something needs to be done and the challenge is so huge, people just kind of leave their egos on the side and they say, okay, let's get to work and who can contribute to what. This tele-ICU project that we launched, it's national. We have signed MOUs with the federal government, with the government of Khyber Pakhtunkhwa, where my family is from, the north of Pakistan, okay, with the Sindh government, and they've been very receptive. We have, you know, monthly meetings with them to updates on what we have done so far. They have organized and facilitated our trips to various hospitals in interior Sindh to look at the facilities, do some, you know, on the ground capacity building for COVID-19 care. And so it's been really fantastic. And I think it was kind of almost the opportunity to make that link. And then we hope to actually build on that. And I'm gonna obviously slide NCDs right onto that partnership. At least I plan to.
We'll sure you'll be successful. As you know, Dr. Pagidipati had to run for another engagement, which is why she had to drop off. One other thing that you mentioned, Zainab, is about some of the challenges for research capacity development. And you mentioned mentoring as one of those, and I know you and I have had some conversation about this. Can you talk about some of the novel partnership ideas that you have around mentorship, and how, to the degree that it's helpful, thinking about mentorship, broadly, yes, within your institution, but also potentially outside your institution, and how we can do that in a digital age?
Yeah, good question, Jerry. So, one of the themes, like you pointed out, that came out and was rather evident to me was mentorship and mentoring. A lot of people would say, okay, what do you mean by that? And we'd ask that question, in fact. And so clearly, that was a big need that came out. I think for me, because it was such an important fabric of my everyday life at Duke, it was like the air you breathe. You're getting mentored by your peers, long day in the Echo Lab, Jerry and Swati having conversations on how things are to be done. Really, it's that's what it was. And I think that that ethos, that principle, that's very transferable. In the program that we're proposing, we're hoping that the mentorship can be done almost in teams. And because we're in a digital age, people who are interested in the growth of careers that will contribute to global knowledge, crossing country lines, that can be done. It's monthly meetings, weekly meetings, working on projects that are important. You not only contribute to research, but during that you're building capacity and growing careers. So that's essentially how we are thinking about it, structuring it in such a way where you have two institutions, mentors from two institutions contributing to the growth of an individual researcher's career.
Excellent, thank you. I think we have time for one more question. Charles Mururi from the Global Health Institute says, great presentation. His question is that, he assumes that there's an electronic medical record at AKU across the various countries. And how do you foresee leveraging that EMR for research?
Yeah, so great question. I mean, Jerry, that's what has made me, been working hard on this. So AKU has this health information management system that's been active for many years, so almost 30 years. But the digital record is very lean. It's not like our EHR where just every single thing is documented in it. There's a lot of paper chart. So when there's inpatient missions, it's paper chart. But when the patient is discharged, when they're admitted, a lot of the documentation is done and codified using sort of standard ICD-9 diagnosis codes, etc. And what we found was, and it's the same system across, Pakistan, Afghanistan, and in Kenya. And so this actually represents to us an opportunity where we can get information on what disease patterns look like across these three different countries. Now AKU is gonna go full on with an EHR, like a true EHR, where you have there's no paper charting. Meditech is our partner, and they're gonna launch in the next 2 years across all three campuses. So that's gonna be a data deluge. Very excited about it. But one thing we've learned from the previous experience is that lean is good. The data should be like the human skeleton. So even after thousands of years, you can figure out what that person's life was like just looking at their bones. So that's how the data ought to be, not cumbersome, but lean.
Every time I hear you speak, I learn something from you. I'm gonna take that skeleton analogy with me. This has been a great visiting professor talk. Thank you so much, Zainab, for making the time, even with the time zones. There are a few more questions in the chat that we'll try to address offline. I want to thank everyone for joining today. Look out for Dr. Samad's second part of this series coming in April of 2021. We'll announce more about that later on. Thank you everyone for joining, and have a great day.
Thank you very much, Jerry. And thank you for all for inviting me.
And have a great evening.
Thank you. Bye-bye.